Hello, let's talk about the STL titled Diseases of the Salivary Glands. Now, if you've been learning the heart or the lungs or the brain or the bones before this, then glandular histology and physiology is kind of a hard left turn from all these other different organ systems. And it's very important to understand glands fully because the gastrointestinal system is packed with them. You see them from the start to the finish. You see glands all throughout. And glands secrete anything. A gland is what we call basically a secretory microorgan. And a gland can be endocrine or exocrine, and that's the real big split. And an exocrine gland is going to make whatever it's supposed to be making and then spit it out into a lumen, a duct, and it's going to drain from that duct into an orifice, for example, the mouth, or into the stomach, or into your small intestine. Or maybe that exocrine gland is going to be draining out of its duct onto the surface of your skin, as is in the case of a sweat gland. And a simple exocrine gland I've kind of drawn here on the right in all red, and understand that you've got a bunch of cuboidal epithelial cells, and they're going to be lining a duct or a lumen, and they're going to make something and push it into that empty lumen, and then it's going to just flood the lumen and spill out into wherever it's supposed to be going. And so you can contrast that with an endocrine gland, which I'm not going to go into detail about here, but understand that endocrine glands push their products directly into the bloodstream. So exocrine glands are secreting into a lumen, and endocrine glands are secreting directly into the bloodstream. And that's the major difference between these two types of glands, because for the most part, it's going to be cuboidal epithelium for both. So we talk about a cuboidal epithelium, and when we're looking at glandular histology, in order to orient yourself, you should understand that whenever you're looking at a tubular lumen, so the empty space in the middle of the cells is called a lumen, and that's going to be called the apical side of the cells. And this is in contrast to the basolateral side of the cells lining the lumen of the gland. And I bring this up because cells have a polarity to them, and they have a polarity, and that means that they have a sidedness. It means that one side of the cell is not the same as the other side of the cell. So the side of the cell that is pushing out all the product, that's called the apical side, and that's the side lining the empty lumen. Now, the basolateral side, that's like the butt of the cell, and that has nothing to do with pushing out any product. That's the back end. That's the hardware, not the software. And the basolateral side of the cell exists to anchor glandular cells to the surrounding connective tissue. So there's lots of integrins, adhesins, connexons, gap junctions, different cytoskeletal elements found on the basolateral side of cells. So that's kind of the compass directions to help orient you in reference to glandular anatomy. Specifically talking about the salivary glands now, they're in your mouth. You salivate, you know what that means. There's 3 pairs of major salivary glands, and they're your parotid glands, your sublingual glands under your tongue, and your submandibular glands. And then there's also minor salivary glands, and you have hundreds, if not thousands, of minor salivary glands, and they're very tiny, and they're simple glands. But the major salivary glands are complex glands, meaning that they have a severely nested branching structure that elaborates kind of like a tree. You know, it branches for many generations, similarly to the lung, the respiratory tree. But these minor glands, they don't branch very much. They're just cul-de-sacs. They're one and dones. So salivary glands can get obstructed, and that's a common root of pathology, is for you to get a stone or a bacterial infection, or even if you have an autoimmunity, you could get a infiltration of leukocytes or lymphocytes up inside of a parotid gland or any salivary gland, and that could cause a direct obstruction of the gland. And so looking at this picture of a gland up here, if you just block off, we'll go back to orange, if you were to just block off the top of this gland and stop it from secreting its contents, what is it going to do? It's going to swell up and get more massive, and then that's going to create some inflammation as the products of this gland are unable to exit into the lumen or the oral cavity, wherever they need to be going. So the gland's going to swell, and that's going to cause a minor immune reaction. And if it's unchecked and if the obstruction continues, then things can get pretty hairy for that gland. So that's the non-neoplastic salivary gland diseases. You can also get cancers of the salivary glands. And part of why I ran through the details of the epithelioid component of glands, the cuboidal epithelioid component of glands, is because that cuboidal epithelial cell is typically going to be the neoplastic cell in question anytime there's a salivary gland cancer. And there are couple benign tumors, couple malignant tumors that you're going to need to know. This SDL is actually particularly heavy on the neoplasms. So without further ado, let's get right into it, and then we'll come back and review at the end what we need to know. Xerostomia is the subjective complaint of dry mouth. It's basically a vocabulary word. It could be included in a test question. And it's going to help you, it's going to narrow your differential to problems of the oral cavity. So it can be drug-induced, specifically antihypertensives, antidepressants, chemotherapeutics. So recognize those classes of drugs for the exam. Salivary gland stones might cause dry mouth. Again, as we were saying, a stone is going to obstruct a lumen of a saliva secreting gland, and so you need saliva to lubricate your mouth. And so if you've got a big obstruction to that, then you're going to get dry mouth. Makes a lot of sense. And then finally, radiation may cause the sort of cell proliferation that could block up a gland, and this would be probably like a metaplasia or a hyperplasia of glandular epithelium. You can also see xerostomia as a often primary presenting symptom of some systemic diseases such as Sjögren Syndrome, which we will talk about today, diabetes, anxiety, thyroid disease, and mouth breathing. But good thing about mouth breathing is that it's solvable. Don't be a mouth breather. So xerostomia is not just dry mouth, it's a tingling mouth. It can be a burning sensation in the mouth. And often patients will present saying, oh, I really need to drink a whole lot of water with meals, because like if I try to eat dry foods like crackers or pretzels or even breads, then it's just very, very hard to swallow and get those foods down, because these patients aren't producing, or rather they're not clearing their glands of all of the saliva those glands are making. And this is a good time to explain that what's in saliva. Well, it's not just pure water. There's proteases and amylases inside your saliva, which are going to help to cut up the food that you eat on a very, very molecular level, because what you're ingesting, most things exist in nature as like very large polysaccharides and polypeptides. Some proteins have hundreds, thousands of amino acids, and some polysaccharides have hundreds, thousands of sugars pasted together. And so you need enzymes that can uncouple individual units from these what's the word? Polymers, so that you can digest them one at a time, because your cells don't, you don't put one globe of glycogen into the Krebs cycle. No, you put one pyruvate from one glucose, and so you need to cut things up. So that's what saliva does. So you understand that, and then it's like, okay, your food's not getting digested, it's going down rough. That's the most common chief complaint here. So important to know this big complication, potential dental caries if dry mouth is not cared for, because the saliva that you secrete helps keep your oral pH at a pretty comfortable zone. And if you're not secreting enough saliva, then you're going to lose your ability to buffer acids. That's very, very important. It's a buffer. Saliva is a buffer. So what that means is that you've got a gland blockage. Let's say you get sweet tea with 4 lemons in it. Are your teeth going to like that? No. So if you don't have saliva, well, then your teeth are just bathing in sugar and lemon juice, which has a pH of like 3 or 2, for the next, until you brush your teeth. So this can very quickly erode the enamel on the surface of your dentition. Another symptom you might see, angular cheilitis, which is basically the corners of your mouth. They're going to turn really, really red. There's a medical word for the corners of your mouth. I forgot it though. Candidiasis, that's not really a specific complication. We'll talk about candidiasis a little bit later too, I think. Or no, we talked about Candida last SDL. These SDLs all blend together. And we'll talk about it with diseases of the esophagus. Yeah, you've got to have a little more going on besides just dry mouth in order to develop oral candidiasis. So stones. Salivary gland stones can be obstructions of the salivary glands. It can be a stone. And they're made largely of calcium phosphate. I think that's potentially helpful to know what these stones are made of. The correct terminology to name these stones by is Sialolithiasis. Lithiasis, you've seen that. Nephrolithiasis, that's a kidney stone. So sialo is just salivary stone. This is the most common disease of the salivary glands. Typically occurs in the submandibular glands because those have to pump up against gravity, kind of like, how the maxillary sinuses are the most common to get a sinus infection. Well, that's because they have to drain upwards against gravity and all your other sinuses are drained down. Well, your submandibular glands are really having to push up and squeeze to get their product out into the oral cavity. So they get obstructed a little bit easier than the parotid glands do. They're going to present with pain and swelling, and it's going to be palpable. And it's probably going to have some point tenderness to it as well. And the big complication here is a secondary bacterial infection. You're worried about staph, obviously. You're worried about some other dental species like strep viridans. You're worried about your Hasex because you know that those are anaerobes up in your oral cavity. And because this is a calcium phosphate stone, you're going to see it instantly on an X-ray or CT. You don't even have to be a doctor. You may be a medical student and see this thing, Sialidenitis, am I saying that right? Sialidenitis, I'm going to roll with that, is a inflammatory disease of the salivary glands. Anytime you see itis, inflammation, thinking red, hot, acute, big neutrophil response. So mumps can give you a sialidenitis. Mumps is a paramyxovirus. From the sketch, we're thinking mumps, mummies, right? And so what are the virulence factors? It's got a fusion protein, which can make multinucleated giant cells. It's got hemagglutinin and neuraminidase as well. It's a single-stranded negative sense RNA virus. It's going to present as a big lump on the jaw. And that's actually how everything in this SDL is going to present, you know, as a lump on the jaw. And so it's like this SDL is the differential for patient comes in with a lump on the jaw. So patients with mumps are going to have an elevated serum amylase. I think that's an important and test-worthy point because we have been using serum amylase to diagnose mumps for a long time now, and so it's probably not, you know, going away, like leaving test questions anytime soon. What does amylase do? It cuts glycosidic bonds. And I just want to remind you that there are alpha and beta glycosidic bonds. And a glycosidic bond is just any oxygen that's kind of linking two 6-carbon or 5-carbon or however many carbon sugars together. It's a bond between sugars. And so if it's an alpha glycosidic bond, well, then it's got both hands up like that, remember? And then if it's a beta glycosidic bond, then it's got one hand up and one hand down like that. And if it's a 1,4 glycosidic bond, then it's going from the 1 carbon of one carbohydrate to the 4 carbon of another, and then a 1,6 is going from the 1 carbon to the 6 carbon of another carbohydrate. And remember that if you've forgotten your molecular nomenclature and your orgo, you're going to have to relearn it before boards. So you see mumps, and typically a pediatric disease. Adults can get it though. You're going to see massive parotid swelling. Again, your parotid gland is right about here on the side of your mandible, like right above your angle, the mandibular angle, kind of where the ramus of the mandible is. And you can tell it's pretty fat in this picture. That's what mumps does. It's got tropism for the parotid gland. And so the reason why the parotid gland swells in mumps is because the virus gets into these cells, and then the immune system, once it recognizes that there is a virus in these cells, well, it just attacks your parotid glands because it says, we've got to get this virus out of here, so we have to kill these cells. And so there's a large lymphocytic response, as is typical of a virus. Again, anytime you have a virus that is infecting cells, it's going to be causing inter or intracellular damage inside the cell. And so cells will take damaged products of damage, and put them up on MHC class 1 molecules. And that's going to speak specifically to CD8 T cells, typically Th1s, the cytotoxic T cells. And the T cells are going to induce apoptosis in virally infected cells. That's the general stage play of a viral infection. So that's what's happening in mumps. Again, the lymphocytes being there and all the inflammation is why the parotid swells. You've got some pretty bad complications to know about mumps, and I figure that's where a test question may be coming from on this upcoming exam. Orchitis is going to be swelling of a testicle, possibly both. If it's unilateral, then that's a good sign, because it's not a good sign, but it's better than bilateral, because if it's unilateral, well, you can still have a kid, you know, but if it's bilateral, then that's when you start worrying about fertility issues. And it attacks the testes because of tropism. Again, the concept of when the virus gets in your body, there's only specific cells it can get into and infect. It's like it has a key that only works in certain doors. And so the testicles have one of those cell surface doors expressed. And then so does the pancreas, which is why you might see an acute pancreatitis following an infection of mumps. And it can also get into the central nervous system as well and give you a meningitis too. So those are 3 bad complications of mumps, which is a type of paramyxovirus. Acute bacterial parotitis is pretty much the same thing as acute bacterial submandibular sialidenitis. The difference is in the locations. The parotid duct, which is also called the Stinson duct down here on the right. I'll use a different color. Right here, when it's talking about the Stinson duct anatomically is the parotid duct. So it's going from the parotids into the sides of your mouth. So if you take your tongue and you feel for that like little, dot-like bump on the inside of your cheek, that is where your Stinson duct opens into your mouth. Now, submandibular glands, those are down here. Those are not up here. So submandibular glands drain into the oral cavity through a different duct. And specifically, this duct is called the Warthin duct. And the Warthin duct is pretty midline, and it's right on the base of your tongue. Remember that your tongue sticks out, but then it's kind of anchored to the floor of your mouth by a thin little membranous frenulum. And then at the base of that frenulum, there's a caruncle, which is about as big as a pencil eraser. And so right where that pencil eraser is at the base of your tongue, you can kind of palpate it, wash your hands before you do. That's where your Warthin duct exits and opens up into your mouth, and that's how your sublingual and submandibular glands drain into the floor of your oral cavity. So number 2 and number 3 here, parotitis versus submandibular sialidenitis. Differential is location. So looking at bacterial parotitis, commonly occurs in the elderly in the setting of poor oral hygiene, most commonly caused by Staph aureus. And again, it's a simple infection, and so it's going to present with possibly fever, definitely swelling, possibly pain, definitely, redness, erythema, especially when eating. And if it is parotitis, here's one more differential. You are going to see elevated serum amylase because the parotid gland secretes a lot of amylase, but your sublingual and submandibular glands do not secrete that much amylase. And so nothing's really going to be wrong with your amylase levels if there's an infection of your submandibular glands. But with your parotid glands, something's up there, yes, amylase levels will change in the blood. So that's your diagnosis. And then finally, I just want to remind you that the side of the mouth, anytime someone's a tobacco chewer or a smoker, or maybe they're a chronic alcoholic, and then in the setting of bulimia nervosa, someone's inducing vomit all the time. Those are a lot of non-traditional routes for the introduction of germs into the oral cavity, besides just, old person has dentures. Last thing, bacterial parotitis, multiple small abscesses. I don't know if that's important. Just now I've said it. So submandibular sialidenitis, whenever you get an infection here, it's in the floor of the mouth, like we're saying parotitis, side of the mouth, wall of the mouth, sialidenitis, submandibular floor of the mouth. It's the Warthin duct again. And then most typically you're going to get an infection secondary to a sialolith, so a stone obstructing that duct can cause a lot of inflammation and can trap bacteria in there, leading to the development of an infection. Again, typically going to be Staph aureus. It can turn chronic. And then if it does, you might get this firm nodule in the submandibular triangle, and that's called a Kuttner tumor. And what that is basically just a backed up lymph node that can't clear out all of the injurious agents within it. One more final topic to note. Big association with dehydration for parotid gland infection, but no such association for submandibular glands. Sjögren syndrome is an autoimmune disease in which your own body attacks and destroys the cells of your salivary and lacrimal glands. So your lacrimal glands, where are those? They're on the upper lateral corners of your eyes if you're looking at the front, right? And then your salivary glands are obviously, you've got 3 major salivary glands, 3 pairs of them. It's an autoimmunity, and Sjögren's can be associated with more systemic autoimmunities such as RA and SLE. And so then you would see the corresponding rheumatoid factor or anti-nuclear antibodies in the blood most of the time for those conditions. Heavy female predilection. It attacks, it's your own body attacking the salivary glands. And if you were to cut open the salivary glands, what you would indeed see is a heavy lymphocytic infiltrate. And it's got this pattern referred to as myoepithelial sialidenitis, or MESA. And the myoepithelial cell is a pretty interesting cell. We'll get there. But MESA has these lymphoid infiltrates. And if you look down at this picture, I mean, it's a lot of poppy seeds. It's nothing but lymphoid cells in here with a few sparse epithelial cells and these ductal structures, 2 of them that I'm circling in red. And what happens is that due to all of these lymphocytes, they just multiply so much and they cause such a reactive epithelial proliferation that there becomes an obstruction within the ducts of the affected glands due to epithelial cells multiplying so heavily. So I want to take a further look at Sjögren's right quick before I do. Here's your bacterial parotitis. And again, remember I said it's the side of the mouth here. And obviously from the outside, you can't tell what that is. You have no clue what that is. Just keep salivary gland diseases on your differential. Somebody shows up with a swollen jaw. And I imagine that a lot of test questions are this non-specific, you know. And then here's your submandibular infection. And this is the Warthin duct here, or the Warthin duct. And you can tell that this is on the floor of the mouth. So remember how we were talking about, you've got this thin membranous frenulum of your tongue, right? And then you've got this, you got this John down here. What did we call it? A caruncle. We called it a caruncle. So this is like normally in normal healthy conditions, fluid is leaving the submandibular glands through this caruncle and going out into the mouth. But then if there's a big obstruction right there, what's going to happen? This is a big swelling, yo. And then you can tell that the way that it's just real light colored right here in the middle, that's not healthy. There's not a lot of blood there. In fact, there's a lot of pus. You can tell that that's a neutrophilic exudate there. And so something important to keep in mind is that, again, you can't make the differential just from looking at this. You have to take full symptoms. You have to get in there and look and do your visual inspection. And if you settle upon a salivary gland pathology, remember that your submandibular glands are down here in the floor of your mouth. So here's Sjögren's. Right here, we're looking at a minor salivary gland with a nodular lymphocytic infiltrate. And specifically, you got a big lymphocytic region right here. There's like nothing but lymphocytes inside that area I just circled. And then you've also got a whole lot of lymphocytes down here as well. And you got a couple of capillaries down in the middle, and that's how the lymphocytes get into the tissues. They extravasate through those capillaries. So we're seeing 2 big clusters of lymphocytes here. And the size of lymphocytic clusters on histology is what's going to be a diagnostic criteria for Sjögren's. You need 1 or more clusters greater than, I think, 50 millimeters squared. or 50 lymphocytes per surface area, whatever that is. So that's explaining it. Here we can zoom in, and we've got some really good normal pictures of glands here. So I want to take a look at that while we're on this slide. Notice that, so here, I'll circle in green. This is one gland, and it's like kind of cut, like if you just cut your finger off and then look straight down it axially. That's how we're looking at this gland. We've got an apical side of things here in the middle, right? That's our lumen. And then we've also got a basolateral side of things around the outside of the gland that I just outlined in blue. Notice that the nuclei are on the basolateral side of things, and that's in reference to the polarity of these cells. Also notice that these cells are pretty washed out. I believe we're looking at some serous glands here. That means they're going to have a watery, proteinaceous product to them. So that's a gland. This whole thing, just familiarize yourself with what ducts, tubular glands, acinar glands are looking like. So back to Sjögren's again, we know we're seeing a lot of lymphocytes and salivary glands, and the lymphocytes block salivary glands, partially because they're there, partially because of epithelial hyperplasia. So that's understood. Now then, what sort of symptoms are we going to see in Sjögren's? Well, you're going to see dry mouth, and you're going to see dry mouth because those glands are obstructed, and so you can't get saliva out into the oral cavity. Couple of HLA correlations to know. Dairy Queen, A1 and B1. And then these are very important here, SSA and SSB antibodies, specifically anti-ROS and anti-LAS. We've slightly seen that before. They're called SSA and SSB because that's Sjögren Syndrome A, Sjögren Syndrome B. This is the disease in which we characterize these antibodies for the first time. And these antibodies are going to be the immunoglobulins, right, that are binding to cells of the salivary glands and attracting lymphocytes to those salivary glands. So that's what this pathogenesis is saying, is somehow, some way, you start making these antibodies. And then step 2 is that these antibodies bind to your healthy tissues, your glandular tissues. Then step 3 is all these lymphocytes follow the chemotactic antibodies. And then step 4 is the lymphocytes just blow everything up, you know, and it's like epithelium gets damaged, it's bloody, it's screaming, it's a war zone, there's fires, explosions, tanks and bombers, and the epithelial just, the epithelium multiplies, and that's how you get the obstruction, the blockage. So again, how does it present? Dry mouth, that's your xerostomia. That's your trouble eating dry foods. And also remember, it affects the lacrimal glands, and so you're going to get dry eye as well. And that's called keratoconjunctivitis sicca. And that's a particularly, potentially, a very, very potentially poor prognosis, potentially poor symptom, because dry eye can lead to corneal scarring, and we know that blindness, especially corneal injuries, are irreversible, virtually irreversible. So if something were to happen to the cornea, you're not going to get that functionality back. There's no drug, really no procedure you can do for the health of that cornea. So that's a big complication, frequently tested. Patients are going to complain of dryness in their eyes. It's going to have a gritty feeling and a sandy feeling. That's how it'll be described most times. And we're going to treat these things with pilocarpine to get these, that's a muscarinic receptor agonist. Remember that acetylcholine And cholinergic receptors induce the activity of glands, and they get those juices flowing proverbially, and that works on both the eyes and the mouth. One more time, dental caries is a complication of dry mouth. You got to recognize that. So back to the big picture of Sjögren. You could see a lot of organ systems involved beyond just the eyes and the mouth. You can see arthralgias tie in with rheumatoid arthritis. You could see some lung involvement. You could see some generalized skin involvement with a small vessel immune complex vasculitis. You can see some gallbladder disease, cholangitis. That's common to Sjögren's. If you get arthralgias, typically you're going to be in that rheumatoid pattern of involvement. Remember, it's going to be the proximal, interphalangeal, your metacarpophalangeal, and your wrist joints. It's not going to be your dip joints. So if it's at the proximal, is that going to be Bouchard's or Heberdine's nodes? It's going to be Bouchard's nodes. Contrast with osteoarthritis, correct? And we don't quite know why some patients only have dry mouth. Some patients have dry mouth and really bad breathing and arthritis. And it's just because the natures of autoimmunities, it's so multifactorial, we can't fully explain why things happen in the timeline or sequence that they do. It's different from person to person. Lab findings for Sjögren's include elevated anti-Rho and anti-La. That's the big thing. Elevated SSA, SSB. So that'll be in your test question. It'll be nice and easy, and you won't forget that it's Sjögren syndrome, A and B. And then you could also see a polyclonal hypergammaglobulinemia. You might see that in the really early stages of trying to get a diagnosis. You know, that might be the initial test you run to see, okay, is there an autoimmunity at play? And then if it is, maybe you're thinking, okay, I need to do something a little bit more specific and get that SSA, SSB antibody test. The anti-Rho antibodies associated with neonatal lupus, and again, we said lupus and Sjögren's might overlap, right? Well, if you're pregnant with lupus, then that's pretty bad because you have a high risk of passing on an autoimmunity to the neonate. And if the fetus, if the child develops an autoimmunity while baby's still in mommy, then that's really bad because baby can't do anything about it. And so baby's just going to get eaten by the antibodies essentially. And so these children come out with organ systems that are often underdeveloped or under attack, you know, like on day one of their life. And so that's really a situation you want to avoid and whenever you can. It's just the problem is you're not always sure that mom has lupus, you know, or like she might be totally asymptomatic. So the anti-Rho antibody is something that we look for in the blood sometimes just because there's a big risk of congenital heart block downstream if mother has anti-Rho in the blood. We diagnose Sjögren's with a salivary gland biopsy, and like we said, positive biopsy is defined as at least one focus of inflammatory infiltrate containing 50 lymphocytes per 4 millimeters squared. And a big complication of Sjögren's is going to be molitoma, which is a mucosal associated lymphoid tumor. That's all I got on that. So a mucocele and a ranula, they're cavities filled with mucus, and they result from trauma, lip biting, lip piercing, maybe hit like boxing, football, basketball, you catch an elbow, baseball, get hit in the teeth. A lot of sports-related injuries here could potentially cause it. Could also be due to obstruction of a minor salivary gland duct. A mucocele is on the lips, and a ranula is either in the floor of the mouth or protruding downwards through the floor of the mouth rather than upwards into the oral cavity. It can go downwards into the neck, and so that's what you're seeing here with that ranula. You got to treat these things by cutting them out. That's about all that there is. So now we move into neoplasms of the salivary gland, and we start with the pleomorphic adenoma. Big number here. 50%, look at that, 50% of salivary gland tumors are pleomorphic adenomas. Do you think you're going to get asked a question about a pleomorphic adenoma? I think so. Generally, the parotid tumors are not going to metastasize or be malignant, and then the smaller the gland gets, meaning as you go to your smaller major glands, then to your minor glands, then the risk of malignancy of a tumor in that gland increases. So there's really no glaring associations or risk factors for salivary neoplasms. However, for the Warthin tumor particularly, smoking is heavily associated. So know that one, but other than that, don't expect any, oh, what's the exposure questions on this exam. A lot of histology, that's going to be where the direction is for these questions. So we know that a benign tumor is a neoplasm that has not encroached outside of its local boundaries. It hasn't broken through any basement membranes. And if it has a capsule, which most benign tumors do, it hasn't penetrated that capsule. Benign tumors symptomatically are pretty painless, pretty slow growers. They might be perineoplastic, but none of these tumors in the salivary glands seem to have any perineoplastic syndromes associated. Malignant tumors, on the other hand, are invasive, meaning that they're going to grow through tissue and they're not going to stop until something makes them stop. They can cut through basement membranes occasionally and metastasize. We know that lysing that collagen 4 in the basement membrane is the first step towards metastasis. Because malignant tumors are invasive, they might compress other vital structures in their surrounding areas, such as arteries, veins, or nerves. And specifically in the face, there's a lot of important nerves running through there. If you get a salivary gland, specifically a parotid gland tumor, you know there's 5 branches of the facial nerves, or that, you know, right there running off. And big chance of compressing one of those branches of the facial nerve just through mass effect if a tumor continues to grow and grow and grow quickly. And that can lead to a palsy or a tingling. So that's a symptom, characteristic, presenting symptom of malignant tumors. Then minor salivary glands. Again, remember, you've got 3 pairs of major glands, and then you've got hundreds of minor salivary glands. Minor salivary gland tumors do tend to be malignant half the time. Let's talk about the pleomorphic adenoma. Again, it's half of all salivary gland tumors. It's a mixed tumor, and what that means is it's got a couple of different cell types within it displaying malignancy. So typically, when we cut open a tumor, there's one cancerous cell type, and then there's usually a lot of other cell types that you will see on histology, but they're not cancerous cells. But in a mixed tumor, you might have an epithelial cell that turns neoplastic, and then you might have alongside it a fibroblast that turned neoplastic. So you've got like subcancer A and subcancer B growing within the same region. So that's a mixed tumor. And in the case of a pleomorphic adenoma, the 2 types of cells you're thinking about are going to be epithelial and myoepithelial cells. That's the mesenchymal component of it, because a myoepithelial cell does have a lot of mesodermal properties. Again, everything in this lecture is presenting as a big bump on the outside or the inside of the mouth. Epithelial and myoepithelial cells. So myoepithelial epithelial cells, they're just like plates. They're like potholes, or I'm sorry, not potholes. What's the dang thing called? What's the manhole covers? That's like an epithelial cell. An epithelial cell is like a manhole cover. It just sits there. It's flat. It doesn't do that much. Myoepithelial cells, okay, those can stretch, those can contract, those can bend and move. And so a myoepithelial cell has a lot of its genome unlocked that an epithelial cell has repressed. So even though they look pretty similarly, a myoepithelial cell does have that extra mesenchymal twist to it that an epithelial cell alone does not. So inside a pleomorphic adenoma, you see a lot of myxoid stroma, and it could be a cartilaginous or chondroid stroma. And it might even get so bad to where you see some osseous metaplasia. And that would make sense if there's a lot of cartilage around, because remember, how does bone develop? Well, first you need cartilage, because most bones grow through this process called endochondral ossification, in which you lay down cartilage and then you send osteoblast precursors through the blood, and then they migrate into this cartilage mold, and the osteoblast precursors will differentiate into osteoblasts, and then they'll begin laying down bone. And remember, that comes alongside the release of a lot of intracellular calcium and alkaline phosphatase, which is going to cut up pyrophosphate. And so there's a lot of free mineraloid ions floating around in the extracellular matrix in this cartilage scaffold. And so it can form seed crystals, and I think osteonectin is the protein that encourages that. And so over time you get the layering down of this crystal called hydroxyapatite, and that's your base unit of bone, and it's a bunch of calcium and phosphate with some other minerals interspersed in between. So that's how bone gets formed. Osteoblasts precursors become osteoblasts on a cartilage scaffold. So that's how you could get an osseous metaplasia, from a bunch of chondroid stroma, as you would see in this tumor. A couple of genes to know: PLAG1, HMGA2. These are oncogenes because it says that the mutations you see in the pleomorphic adenoma are associated with a heightened expression of these genes. So gain of function is an oncogene, a loss of function will be a tumor suppressor gene. And pleomorphic adenomas rarely recur. However, you might have, we're going to see it later. That's all that I'll say. So let's take a look at some pleomorphic adenomas. This is how they're going to present grossly, visually. Again, they're going to be on the inside of the mouth. You can tell that this one is this dude coming from a submandibular gland? No. What gland is that coming from? Parotid gland, probably. This here, is that coming from the parotid gland? No. This on the interior mucosa of the upper lip is probably arising from a minor salivary gland. Again, that's the type that you have hundreds, thousands of. So again, typically slow growing mass, not very painful if you press on it until it gets super big. And then just from where this is at here, can you see how that can compress a nerve? That's a pretty big tumor right there. Histologically, this is what we're looking at. I want green. So we're seeing some squamous differentiation here in the middle, a lot of keratinization, and I wouldn't necessarily call it, this here I might call a keratin pearl, you know, that's our buzzword for squamous, but a whole lot of keratin here. It's kind of deep reddy pink, and there's not a lot of nuclei in there, and it's surrounded by a bunch of epithelial cells, so you can say, okay, that's probably just a bunch of keratin deposited somewhere. We're seeing some mucinous metaplasia, which is a hallmark of the pleomorphic adenoma. If we zoom in on this cell here, mucinous cells are going to have a washed out appearance, and mucinous cells, well, what is the number one type of cell that makes mucin? We've seen it in respiratory epithelium. It's called the goblet cell. And remember that the goblet cell has a really ovular type shape to it. Same thing here. It's shaped like an egg. Look at that cell is. And so is this cell here too. And you can tell it's washed out. Well, why is it washed out? Well, because any mucinous cell contains within it a bunch of sugar, because that's like the main component of mucus is a bunch of polysaccharides. So when you go to prep a slide, you have to wash it with formaldehyde. And then when you wash a tissue before you put it on a mount, then you wash out all of the sugars in that tissue, because you're washing it with a pretty solving material, a polar solvent, right? And so what you wash a tissue with is going to bind all those sugars and pull them out. And so that's why these cells appear washed out. So there's your mucinous component along with your epithelial component, the keratinization here. Up in the upper right corner of this slide, we're starting to see some myxoid stroma. Make that a little bit bigger. Right up here in that corner, you can tell it's highly acellular and washed out in places. We did say the pleomorphic adenoma is a mixed tumor consisting of epithelial and myoepithelial cells. I'm going to point out some of these myoepithelial cells for you. I'm going to have to zoom in pretty far to do it though. So I'm going to go green, and like here around the outside of these lumens are myoepithelial cells. And they are, it is true that they are pretty visually similar to epithelial cells. However, you can tell that their nuclei are a little bit bigger. They're a little bit bigger cells, and they're also not lining a lumen. So now I'll highlight our normal epithelial cells in red, and it's going to be like, there's the apical side of those epithelial cells, and it's like, there we go. So there you can see that we've got myoepithelial cells on the outside and normal epithelium on the inside. Makes sense because myoepithelial cells have a connective tissue component, so they would be holding together glands and ducts. And as we move throughout, here's a lot of myoepithelial cells down here. I'll highlight this too. Just this area down here, myoepithelial cells and fibroblasts. That's all that's down here. Like this cell in particular is myoepithelial cell. And you can tell that it's capable of laying down some sort of extracellular matrix, but it's got a really myxoid type of washed out nature. Another good example of myxoid stroma. A lot of epithelial cells, but then as you start seeing jagged cells with like kind of pointy, triangular, spindly shapes to them, those are your myoepithelial cells. Trying to circle a good amount of them right here. That's a myoepithelial cell. And what next? Here's an example of that cartilaginous differentiation. Down here, we've got our tumor component, right? We've got our epithelial and myoepithelial mixed tumor, two cell types with some mucinous myxoid stroma differentiation. But then up here, there's a lot of cartilage nearby, and it's blue, and not a whole lot is blue on an H&E stain. It's either pink or purple. So the fact that it's a dusky blue cartilage. Here we even see some bone. That's this pink strip right here. And then on the other side, we're seeing some adipocytes. And this is an example of the type of extreme cellular differentiation that can occur if a tumor is just left in place for a decade plus. And then we zoom in here on our neoplastic component, which is on the left side of the screen. And what are we seeing? We're seeing a bunch of glands with washed out hollow lumens, okay? We're seeing some mucinous differentiation right there, right through there, some mucinous type cells that are washed out. And then we're seeing some myoepithelial component to this as well. I won't point out the individual cells, but again, if it's got some pointy ends to it, like spindle cell, why is it called a spindle cell? It's got points on it. And those are your myoepithelial cells. This is a beautiful picture. A lot of cartilaginous stroma. Again, you're looking at the ducts, and we're noticing you got a normal epithelial cell component. I'll go back to red for that. You got a normal epithelial cell component directly lining the duct. That's a strip of them there. But then you also have these myoepithelial cells that are a little bit bigger, a little bit darker nuclei. Like that's a myoepithelial cell right there, you can tell. That's a myoepithelial cell. Important to remember, it's a mixed tumor. So that is all that I'll say about the pleomorphic adenoma. Now let's talk about the Warthin tumor. It's a benign tumor. It's associated with chromosome 8p deletions, 9p deletions, and then there's a subtype with this 1119 translocation, which we're also going to see in the next tumor, the Mucoepidermoid Carcinoma. So understand that same translocation, two different tumors, makes me think there's probably going to be a histology question on the test that is the differential between these two. Strong link between Warthin tumor and cigarette smoking. It is super worthwhile to know that Warthin tumor occurs almost exclusively in the parotid gland. That's a really ugly box there. That's better. And the Warthin tumor has a very characteristic histology. I mean, can't miss it. Can't miss it. You're gonna see this and remember it. The Warthin tumor has got a double layer of epithelial cells on it, and you can't see it that well in black and white, but if you zoom in, you notice this layer of epithelium has two distinct rows of nuclei, and I'm drawing a dotted line in between the two rows of the nuclei, and you can straight up tell that like there's a top and a bottom layer of these epithelial cells, and it's because one layer is columnar and the other is cuboidal. So the cuboidal one is short and fat, and the columnar is tall. But then inside, contained within this epithelium, is a large population of lymphoid cells, lymphocytes, and the lymphocytes might develop a follicular or germinal center, which is this light patch you see right here. B cells are prone to do that. And here's another slide showing you the same exact thing, double layered epithelium with a lymphoid infiltrate. So that's got some very easy histology to it. We're fortunate for that. Again, it's a benign tumor, painless, slow growing. It's typically not going to metastasize at all. And it could be filled with brown fluid reminiscent of motor oil. And that just sounds like something they'd throw you on an exam just to see if you can catch it, you know, or try to throw you off or something. So the Mucoepidermoid Carcinoma. Okay, benign tumors end in oma, but malignant tumors end in carcinoma or sarcoma. And if it's a epithelial tumor, it's going to end in a carcinoma. So that's where we're at here. We're into the malignant neoplasms of the salivary glands. Mucoepidermoid, well, you can tell it's going to have a mucus component, really big mucus component. And then again, you can tell from the carcinoma, it's a malignant epithelial tumor. Most common cancer of the salivary glands, and I underline that to remind you that we don't want to call benign neoplasms cancer if we don't have to, if we're not fully equipped with all the information we can have on it, you know, because that's a bad word to have to throw at somebody and kind of force them to carry around with them. You just call it a mass, call it a tumor, call it a neoplasm, call it benign mass. You know, there's a lot of different ways to name that besides slipping up and calling it cancer. But if it's malignant, it's cancer at that point. So strong mucin component. Histologically, here at the top of page 13, it's telling you you'll see mucin-filled cysts within nests of squamous cells. They're large, cuboid, or goblet-like and filled with PAS-positive mucus. And there are different grades of mucoepithelioid or mucoepidermoid carcinoma. And remember, the grade is talking about the growth of a tumor. So to determine the grade of a tumor, we're going to put it under a microscope and look for things like pleomorphism, atypia, differentiation. And so it's telling you could have a low grade or a high grade mucoepidermoid carcinoma. The hallmark is a 1119 translocation. Yet again, it's the CRTC1, MAML2 fusion. Same fusion as you see up in the Warthin tumor. Let us take a quick look at the mucoepidermoid carcinoma. There we go. So here's your epidermoid component. I can't say my damn R's, and it's really pissing me off. There's your epidermoid component. Here's your mucin component down here. Oh, that's a big nest right there. So washed out cells, goblet type cells, they get washed out because they're filled with sugar. But if you drop some PAS on them, they'll probably light up hot pink. Another mucinous component there, some mucin spaces there, mucin, and fibroconnective stroma throughout, connecting the epidermoid component to the mucus component. Don't forget about the translocation. Another picture of it described in the text as having nests or cords even of squamous cells with focal keratinization. So your mucinous product is kind of here in the middle of this lumen, and then your squamous cells are all throughout, and focal keratinization is pretty much referring to all the cytoplasmic accumulation within these cells. Don't really see a lot of keratinization in this tissue section. All right, let's get back to the text. The adenoid cystic carcinoma is another malignant tumor carcinoma, epithelial malignant neoplasm. It's got what's called a cribiform pattern, which we're going to take a look at shortly. It's locally aggressive, and remember, these aggressive carcinomas like to expand and encroach and invade into nervous tissue. So you might see a handicapping of a given facial nerve, a given region of the face corresponding to such a nerve. It can be pain, paresthesias, that's going to be tingling, electrical sensations. Might also be in the trigeminal distribution. So those are cranial nerves 5 and 7. Adenoid cystic carcinoma is associated with a 6-9 translocation involving the MYB oncogene. And that reminded me of the MYC fusion gene in Burkitt's lymphoma, in which there's an 8 to 14 translocation. And this MYC protein gets plastered on to the immunoglobulin heavy chain. And this is a pretty benign translocation, except for in B cells who make the immunoglobulin heavy chain. Like, that's all that they do with their lives. They just sit around making immunoglobulin heavy chain, you know? So every time you make an immunoglobulin heavy chain, as you process that section of DNA, well, you also have to transcribe this MYC protein. And then what results out of that is that you have 100 times the amount of MYC on the surface of your cells that you need. And well, what's MYC? Well, it's a transcription factor that's going to upregulate cell growth, and it's going to provide a competitive advantage to those B cells that have this upregulated MYC. So that's Burkitt's lymphoma. That's a B cell lymphoma. You see one B cell get this mutation and just pops off. Back to adenoid cystic carcinoma. On histopathology, you see this Swiss cheese pseudoluminous cribiform pattern. Best way I can describe it. A lot of PAS positive material or basophilic mucinous material. So it's a mucinous tumor. Should make sense. It's a cystic carcinoma, right? So that means it's going to have a lot of fluid inside of it. And indeed, if we zoom in, here's the cystic part. I mean, geez, there's nothing there. And can you see why they call it like Swiss cheese pseudolumens? Yes. So it also mentioned the stroma is commonly dense and hyalinized, and by that we're referring to the area in between cells. So I'm kind of trying to outline the stroma here, like that. Everything in between the lymphocyte or the epithelial portion of this cancer, that's the stroma. It's really hyalinized here. Like you can tell there's a strip right there, that anuclear strip, whoops. Right there, yeah, there's like no cells in that area. That's the hyalinized stroma. So that'll tell you, plus all the massive cystic mucinous spaces that you're looking at this ACC, adenoid cystic carcinoma. And it's a carcinoma because it's a cancer of cuboidal glandular epithelial cells, and you can tell that the lumens, the architecture there, has been preserved somewhat. Another example, this is the cribiform architecture it's referring to. Very clearly cystic. All these glands are filled with a mucinous product. It's just, they're filled with fluid, and the cancer is an epithelial cancer. So back to the text. We've also got an acinic cell carcinoma. This one is malignant too. Acinar cells are large polygonal cells with basophilic granular cytoplasm and round eccentric nuclei. That's what you got to know. And they're filled with PAS positive cytoplasmic zymogen secretory granules. And a zymogen is basically a pre-peptide, a pre-hormone that has to be modified or cut somewhere in order to produce an active hormonal product. So it'll stain PAS positive, which PAS is our hot pink highlighter stain. Other than that, I mean, this is very, very similar to all the other malignant neoplasms we've seen thus far, and that it could encroach upon a nerve, cause paralysis. Why can it do that? Because it's invasive, because it's malignant. So let's take a quick look at an acinic cell carcinoma, and we're seeing these large polygonal cells with basophilic granular cytoplasm. And these are, it's a really pretty tumor, honestly. But polygonal, okay. What does that mean? It's got a weird shape and some angles to it. And they are large indeed. Like, that's a pretty large cell. that is also a pretty large cell, especially in comparison to like its neighbor that's got like no room for itself. Over here, I hope you can again see the polygonal shape of everything. It's like that one's kind of like pentagonal. This one down here is a little bit rhomboid. This dude is just a blob, right? So these are pancakes of cells. Like they're just fried egg cells kind of, and they're speckled, but they're not neuroendocrine tumors. They're acinar cells, so they're secreting something. So similar to neuroendocrine tumors, right? Why are neuroendocrine tumors speckled, salt and pepper, and basophilic? Well, they're secreting things constantly. Same thing here, your salivary glands. There's just no neural component to these cells, so they won't pick up your neuron-specific enolase, your chromogranin stains. Here's another example. Where's the cancerous cell population in this image? Where is it? What side of the screen is it on? Well, looks like there might be a little bit over here, but I don't think that's the cancer. I think right over here is really the cancer. Going up and over here. And if you zoom in again, salt and pepper cells, so they're secreting something. What are they secreting? PAS positive cytoplasmic zymogen granules. There we go. 2 more malignant tumors, and we're out of these salivary glands. So a mixed tumor again is technically one tumor, like geographically, spatially, it's one tumor, but there are 2 different cancerous cell types within that tumor. And remember that the pleomorphic adenoma is a benign mixed tumor. So these 2 malignant mixed tumors are going to evolve from the pleomorphic adenoma. The first type you can have is the carcinoma ex pleomorphic adenoma. And then the second type that you can have is the pleomorphic adenoma that metastasizes. And the big difference is that the metastatic pleomorphic adenoma, I want some red font. Where's my red font? So the metastatic pleomorphic adenoma down here at the bottom, it is benign. It is histologically benign. And it does not display, if you go to grade it, the features of malignancy such as atypia, weird mitotic spindles. You know, sometimes you see like 4 mitoses all at once. It doesn't show any of that. It looks just like a pleomorphic adenoma. It's just in the lungs or in the spinal column or somewhere. Versus the carcinoma. Well, a carcinoma is a benign epithelial cancer that's progressed or evolved. And so it used to be benign, but now it's malignant. And what visual changes on grading are associated with malignancies? And some examples of changes you would see with malignancies are strange mitotic spindles, dedifferentiation, pleomorphism, which is variation in size and shape. Again, because these are malignant, they might invade, causiofacial nerve palsy. Both of these types can metastasize. The big difference is that in the histology, one's more benign, one is more obviously malignant. So to conclude things, let's take a look at these. Here's your carcinoma ex pleomorphic adenoma, and the type of things I'm seeing here are, first and foremost, you've got this just dumb mitotic figure right here. Like what are you doing, cell? You know? So if you saw something like that on the test, they would be trying to lead you to, oh, this is not a benign tumor, this is a malignant tumor. And then with this section of tumor, this is also what was it? Carcinoma X pleomorphic adenoma. That's also what we're looking at here. And then I'm seeing a lot of neovascularization down in the lower right quadrant. A lot of new capillary formation just all over the place, especially down here though. So capillary formation, vascularization often proportionate with the severity of the tumor grading wise. And we're also starting to see a little bit of dedifferentiation up in here. You know, these cells are not really conforming to an epithelial or a mesenchymal shape. They're getting more and more and more myxoid, and so they're getting more loose. And so you could say that there's a dedifferentiation to them as well. So that's how I would spot a malignant tumor from a benign, because again, there's a couple of benigns, couple of malignants in this lecture. Look for the weird mitoses, look for the blood vessels, look for the vascularization. Down here is a good example. If it's red or pink, if there's a lot of red or pink inside a lumen, it's probably blood cells. So that's what we got for the parotid glands. Let's recap. You're going to get a Sjögren syndrome question, I imagine. I mean, there's like 2 whole pages on that. You're probably going to get a question on the Sialidenitis section, because all 3 of those are going to present very, very similarly with the swollen parotid gland. Definitely going to be 2, maybe 3 neoplasmic questions. The pleomorphic adenoma is going to merit a question on its own, so please know the histology for that. Other than that, we've got a lot of genes get brought up in this SDL, and so you're going to have to know the different translocations. I know it's a pain, but you're going to have to know the translocations. And then also the histology does get described pretty well for all of these tumors. And so know your histology, and what's going to help you make a differential is, are you seeing symptoms of pain, point tenderness, and nervous involvement within the face? So that's it for the salivary glands. Thank you very much.